Today's episode of Beyond the Mask is presented by the insurance specialists at Bright Think Wealth Strategies. Find the disability insurance coverage that fits you best right now. Email Robert Smith at rsmithjr@financialguide.com. The show is also made possible by the team at CRNA Financial Planning. Get a free consultation today to be guided through the complexities of investing and financial planning. Just visit crnafinancialplanning.com. We'd also like to thank Helping Hands and OSA EMR for their support of the show. And don't forget, listening to our podcast can earn you Class B credits. For more information on how you can submit them, check out the CE Credit tab on our website, beyondthemaskpodcast.com. Welcome to Beyond the Mask, Innovation and Opportunities for CRNAs, with Jeremy Stanley and Sharon Pierce. We know you spend your day caring for your patient's best interests. On our show, we want to care for you. Join us as we leave the operating room and learn the latest in the CRNA industry. Beyond the Mask starts in 10, 9, 8, 7.
Well, hello, Sharon, and hello to our listeners, and welcome to the show.
Oh, it's good to be here. Of course, I'm not with you right now.
No, you're off having a girls' trip.
I am. I got my good friends down here, Tracy Castleman from New Jersey, and Dana Peterson, my ride or die from Charlotte, and of course, Judge Woods down here. So we were listening to oral arguments for the Court of Appeals this morning for fun.
Wonderful. It sounds like a weekend that I would love to have with the boys.
I'm sure y'all wouldn't be doing that, but it was pretty fun. We learned a lot.
Well, good. And on that note, let's kind of change it up a little bit here because that sounds boring to me, but I'm just saying.
Who said we weren't drinking mimosas?
Oh, there you go. I knew the truth would eventually come out. You know, the wine was flowing while we're listening to oral arguments. You know, that sounds more interesting to me. So.
There you go. Well, that's our brand of fun.
Oh, good. Well, you know, we have a great show lined up today, and I know you're excited about it. And the more I've done a little bit of research on our guest, I've gotten even more excited about having him on today. So today we have Scott Becker. Welcome, Scott.
Well, thank you, Jay, and thank you, Sharon. It looks like you guys have a lot more fun than I do, so I'm looking forward to joining you today on today's podcast and show. Thank you so much for having me.
Well, Scott, I'm going to do a little bit about your background, and I'm going to let you take over because the more research I did on you, the more impressed I got, and you know, I could probably take the whole show and read about your background, but you're a partner in the healthcare department at McGuire Woods. And you're also the founder and publisher of Becker's Hospital Review and Becker's Healthcare, which in itself is just an amazing feat because I was reading you guys have almost 3.5 million subscribers, which is absolutely amazing. You also have something in common with Sharon. You're a Harvard Law graduate.
Yes, we try not to tell anybody, but yes, we did graduate from Harvard Law School, but a lot earlier than Sharon did, but yes, a long time ago.
Oh, no, he's messing with you because I went to Yale.
Yeah. And you know, you're also a CPA as well by background, so that's always interesting to me. So as we kind of kick this off, Scott, why don't you tell us a little bit more about your background and how in the world did you get into Becker's Healthcare and kind of evolve from where you were to where you are now?
Sure. No, and thank you so much for the question. So I started Becker's Healthcare literally 30 years ago when I was in my 20s, and really apropos of something totally different than it ended up being. So Becker's Healthcare ended up being a significant sort of media company. Really, our audience is hospitals and health system leaders, orthopedic and spine surgeons, surgery centers, hospitals, health IT, digital health. And within that, of course, anesthesia plays a big part in everything. Right. So we've ended up with also, some falling amongst CRNAs, the AANA and others. But really, we ended up building the media company, which now has, 5-6 large conferences a year. President Bush, Ariana Huffington just spoke at our last event, Peyton Manning, Magic Johnson before that. And just really a great deal of fun. We've had Bill and Hillary Clinton and a whole number of sort of, really interesting speakers across the board, meetings digital, we have a podcast, and it's been a labor of love and has put us in the middle of sort of the core of the healthcare industry. By background, as you mentioned, for better or for worse, Harvard Law graduate, started the media company 30 years ago, really not intending to build a serious media company. When I first started it, I was trying to build a brand as a young lawyer, and that was sort of the first part of the journey. Then at some point, it became truly a media company versus a marketing effort. Now we've got 100 plus employees, 30 full-time writers, lots of people that plan events full-time, a key account management team, a sales team, an event team, and so forth and so on. And it's really been, a great pleasure. So had a chance today to, for example, to visit with the CEO of one of the University of Massachusetts health systems. Earlier today, the chief strategy officer of the largest not-profit behavioral health system in the world, in the country. And I get to visit with really interesting people, and it's just been a great pleasure to be in the middle of it. But that's really was the start of it. I had a chance to visit with the president of the AANA, at least the immediate past president, Dina Valachi, and that's been fascinating as well. So we get a chance to visit with people just really across the spectrum, and a great pleasure. And thank you for having me.
Yeah, absolutely. Well, it is kind of funny how we get into business and we think we're going to go one way, and then life and business kind of lead us in this other path. And, you look back and you go, wow, this has kind of been a curvy path, but what a great ride. It sounds like the same for you.
No, 100%. It's been, I've ended up straddling two careers forever, that of being a lawyer at a large firm where I chaired our national healthcare practice. I really say when I talk about this in depth, built my legal practice in my 30s, built the media company with a great team. I mean, the core that runs through all these things is sort of two things, all in healthcare and all built with great teams. And it really built the media company in my 40s, and have had just tremendous fun with it, with both. And great teams, and really focused in the healthcare arena.
Well, I think today, our topic of conversation, which we could have went, in a multitude of different directions with you, but we're really going to be talking about the future of healthcare and kind of get your take on that. But more specifically, because the majority of our listeners are CRNAs, the CRNA's role in the future of healthcare, and all that's going to kind of lead into probably a lot of different directions. But that's kind of where we want to take this today. And Sharon, I know you had, a couple questions that you wanted to start off with, so I'll let you start because, as you said, Scott and I are you're probably going to take a fire hose to us as soon as I get started with him. So
I will. So again, this episode is going to be the last episode that airs for this year. So we are forward facing, looking towards 2023. And you have your finger in a lot of different pies, as we have just heard about. So why don't you give us an overview with all of the things that are going on in healthcare, and you're looking into your crystal ball right now. What do you think 2023 is going to bring overall for the healthcare system? And we'll hone into how you see CRNAs just fitting into that puzzle after you take your first swing at this.
Sure. Well, I'll start more neuro. I'll start neuro because it's relevant to your audience. I mean, there's, and then I'll go a little bit deeper and broader. There's first and foremost, at least for neuro, is there's a huge shortage of anesthesia providers throughout the country, and that's causing huge challenges for health systems, for surgery centers, for anybody that needs anesthesia. Huge shortages, and it's fascinating because you've seen a worldwide sort of change in perspective amongst medical doctor, anesthesiologists versus CRNAs, and that world that's inhabited. If we went back 10 years ago, this was a tremendously territorial relationship. Medical doctor, anesthesiologists were doing everything they can in every market to keep CRNAs out. They viewed them as a source of competition, something to get in the way of them making a living, so forth and so on. At this point, it's almost as though medical doctor, anesthesiologist, MD anesthesia has thrown up the white flag, and not the white flag in terms of like, oh my God, we're not prepared to keep on working, we're not prepared to keep fighting, but sort of understand the shortage of anesthesia providers is so significant, so challenging that no one could do this without the greater help of CRNAs and others. So I start sort of neuro, moving from this huge territorial fight that was going on for 10, 20 years. Anesthesiologists trying to get the federal government to change the rule. They changed it to where states could opt into CRNA only with supervision of a doctor and so forth and so on, to having these fights across state lines, to now many, many states allowing CRNAs to practice alone, and quite frankly, medical doctor anesthesiologists done with this fight. I mean, their fights are much broader today. The medical doctor anesthesia, the anesthesia community is more aligned in fighting things like the No Surprises Act, medical billing issues, and getting just really walloped by payers than fighting each other. And it's really fascinating. Sort of the enemy of my enemy is my friend. And what's happened with CRNAs and medical doctor anesthesia is this huge movement towards where they're really aligned against the large payers and towards Medicare, trying to get paid better by CMS, but really so much challenge from the large players. The No Surprises Act, which on its face sounds really nice, but was really, really a pro-payer law, is really borne out that way. And it's caused tremendous challenges in the anesthesia provision, anesthesia profession, CRNA, and medical doctors, and just a real challenge. So I sort of start there. Then I look at going more broadly, hospitals and health systems facing probably the most crises financial times we've seen in my career, in my lifetime, and probably Sharon and Jay's as well. We just saw today, Providence Health System, one of the largest not-for-profit systems, reported $1.2 billion loss. And you see this across the ecosystem. I mean, health systems that used to rely on different types of procedures, different types of surgeries, different types of things to make their numbers work, they've got sort of flat reimbursement in a situation where inflation, labor costs, supply costs have gone through the roof. So you're seeing sort of mega losses at the mega systems. You're also seeing sort of tied to that, another announcement today of a small health system merging into a large system. And again, we're talking about a month before this episode's released, but either way, it gives you a sense of what's going on. But the same trends will carry through with this year into next year. Another health system in Mississippi, sort of again throwing up the flag, saying we've got to merge with somebody. So sending out an RFP to find buyers, to find suitors, and so forth. The last 2 to 4 years during the pandemic, health systems received a tremendous amount of financial support from the federal government and state governments that let them float through and make it through the last few years. A very daunting period. I don't want to understate how daunting it was emotionally, psychologically, physically wise, and everything. But financially, health systems recovered because they got tremendous help from the federal government and state governments. Now with that aid gone, health systems are very exposed to real challenging market factors. They've got reimbursement is flat, costs going through the roof, and these are real challenging things. And it's not like some people could say, in the old days, people might have said, well, the health systems don't deserve that much empathy, this, that, the other. The reality is, though, if the pandemic proved anything, for all the different challenges out there, we do need the large health systems. I mean, even now, we're in the fall, winter 2022, we've got, again, bed shortages throughout the country. There's not enough hospital beds for the amount of people that are suffering from viruses in certain places. Certain places in California, they're putting up tents again. In Chicago, there's a horrible bus accident with local kids in it. They didn't have hospital beds for the kids. I mean, just to bring the kids back to the Chicago area because we're out of hospital beds. And so many places in this drive towards efficiency, we don't have the hospital beds that we need in a lot of places. So whatever the economic model is, it's a challenging spot for large hospital and health systems. And we probably still need the hospital and health systems. So that's a challenging spot. So we've talked about CRNAs and anesthesia. We've talked about large health systems. Then I guess the third thing we'll talk about is there are lots of new competitors trying to dig deeper into the healthcare ecosystem. And I'll look at those in two ways. There's 4 of the largest companies in the U.S. out of the top 20 are payers of some sort. There's United Healthcare and CVS, were by any measure 5th and 6th in the country in terms of total revenues, just after sort of Apple, Walmart, Amazon, Apple, I think Exxon, Chevron, ExxonMobil this last quarter because oil prices were so high. Yeah. But CVS, United are generally 5th or 6th in terms of total revenues in the U.S. And then you've got still, after that, you've got CVS and United, then you've got Cigna, and you've got Anthem, the former Anthem, which is now Elevance, but another. So 4 of the largest 20 companies in the country are payers. Many of those payers, CVS and Walgreens, which is partnering with Cigna on something, are working hard to double down, triple down, quadruple down on their primary care presence. And you've seen this for years, but they seem to be getting more serious about it. So if you looked at this over the last several years, everybody in most of our communities has a CVS. It depends which area you're in, whether you're CVS or Walgreens. But all of them have built out these health hubs. And what they found was all those health hubs were largely unstaffed. So you go into them, and like at least in my community, you kept on going to urgent care to the major health systems because they had great urgent cares in lots of locations, and they were staffed. The CVSs weren't staffed. There's just not enough doctors out there. But you do see a situation where CVS, Walgreens have each put huge money into trying to buy into primary care networks to try and build out some of those. And that is fine and okay, but there's just not enough doctors right now in our society. So you've got an aging, growing population, 330 million people, and you've got a situation where there's just not enough doctors, nurses, providers, techs, everything to serve them. And that's sort of when I look at sort of that issue, the supply-demand imbalance of our growing, aging population versus the supply of help, that is just a real challenging issue that will take some serious thinking to address and try and figure out. You know, and people think there's easy answers to it. Oh, we move to just prevention, we do this, we do that. But none of those have proven to be easy answers. In countries where they moved to straight prevention, what they found was during the pandemic, they were just overridden with patients and not enough staff to take care of them. So the idea of just we're going to do everything through prevention, it's a wonderful idea. It's a lofty goal, but I don't think it's reality for a lot of us. But we'll see. But so those are three big trends, and I'll turn it back to you too.
Yeah, so I mean, Scott, you just said a mouthful there. I mean, you know, I think if we could solve even a quarter of those problems, you know, you and I would probably be richer than Bezos. But unfortunately, they're tougher, harder issues there. So let's just kind of talk about the shortage for just a minute, because, you know, like I said, the majority of our listeners are CRNAs, and there's obviously a shortage of anesthesia providers out there. And I do a lot of talking for CRNA schools and so forth. And I tell these students, I can't call them kids, but they're students, you know, that what a great time to be a CRNA. I mean, if you look at, you know, just all the dynamics taking place right now. I mean, you know, the average age of an anesthesiologist is in their 50s. The average age of a CRNA is in the low 50s. You know, obviously the graying of America, you know, as we get older, we tend to need more maintenance. We need a hip. We need, you know, all these things, which leaves more surgeries and more anesthetics out there. So I think it's a great time to be a CRNA. Now, along with that, you know, and it's probably something we don't want to go down that road with you today, but there is still some animosity between the MDs and the CRNAs, and then we add AAs in the equation. But as I look out and just look at the pure numbers and just extrapolate that back, I would say that I don't know that there's been a better time to be a CRNA ever. What are your thoughts around that?
No, I think that's really right. I mean, I would say that that's really right with one caveat. One is that, yes, CRNAs starting salaries, the amounts they're being recruited for, the dollars that are being thrown at them are higher than ever, particularly by health systems that have no choice, but because they need bodies to be able to do surgery. They just can't do it without the CRNAs and anesthesiologists. And you've got that in sort of some surgical groups, surgery centers as well. The only sort of caveat I would say is that, but yes, there's just a huge need. And so that leads to supply, demand, and salaries getting better. The only challenge I would say is that the money coming in for CRNA and anesthesia services from the big payers is getting slammed some. And so you've got a bit of this imbalance where anesthesia groups, whether CRNA-driven groups, doctor-driven groups, are asking for bigger and bigger subsidies from hospitals and health systems.
Right.
And they're often getting them right now.
Yeah.
But at some point, there's a real challenge because they need those subsidies because payers aren't paying fairly enough for those services.
Right.
So you've got this real challenge. And the negotiating leverage of the CRNA and the MD anesthesia community has been cut in half, cut off at the knees by the No Surprises Act. So right. You look at something and you say, yes, they're commanding great salaries. The unfortunate thing is they're often through subsidies. And when they're through subsidies, the person paying that subsidy, meaning the system paying that subsidy, is always looking for ways to figure out how to get around it.
Right.
So I would say you've got a real, absolutely. You're seeing numbers in Chicago, for example, starting CRNAs. I've heard numbers are thrown around like 250, 280, 300,000, numbers that were unthought of or unheard of for CRNAs a few years ago. Just not even in the realm. It used to be,
right.
You made $150,000, maybe $200,000. And you had a great career, you had much better balance of life,
right.
And you had a great living. Now you're seeing numbers that are, better than what you make coming out of the elite law schools and stuff like that, which all good. God bless. They deserve it. But it's a very different game. The challenge is the people that ultimately pay for it the payers, employers, and so forth have so much leverage that it's being paid through subsidies and so forth. So we'll see how this all plays out. But yes, it's a great market to be a CRNA.
I remember, and I'll let Sharon get a word in edgewise.
I knew it was going to be like this. It's
but
okay.
We interviewed Randy Moore a few years back, and we kind of had the same type of discussion with Randy. And Randy's a smart guy, and I kind of asked him the same question. And one of the things he said is something that I've realized over the past few years, especially my wife is a CRNA as well, and she does 1099 locums. So obviously the pay for them has gone up dramatically. But I think we've got to be real careful in the CRNA community, to your point, when pay is commensurate with what MDs are making or close. Then one of the positives for CRNAs is that they've been the lowest cost provider out there. And when we
with the highest quality
or the same quality, let's put it that way.
Exactly.
I think that's where the issue can start to break down a little bit, especially as I'm sure you're going to talk about, with healthcare costs being, even more political than it used to be when we're running about 20% of our GDP for healthcare. The government has taken notice of this. And actually, I think the government is the biggest payer of healthcare costs in the country now, or pretty close. So, I think that's one of the things we've got to be really cognizant of in this environment as well, because salaries can't continue to go up, to your point, because, somebody's subsidizing that, and eventually we all know that those subsidies go either somewhere else or they get cut off or dropped back to a certain point. So.
Sure. So Medicare, Medicaid's the largest payer in the country combined. Medicare, Medicaid's the largest payer in the country. But then commercial insurance still 40 to 50% of the dollar throughout the country in different places, different markets, different specialties, and so forth and so on. But yes, between Medicare and Medicaid, that is the combined, the government's the largest payer. In terms of the biggest challenge, again, CRNAs are often a substitute for medical doctor anesthesiologists, so that the pay gap should close, because they're often just substitutes for each other, at least in a lot of different situations. So that cost should close, because they're doing the same thing at the end of the day. And again, the medical doctor anesthesia, there might be some training where for certain types of complex cases, you really do need a medical doctor anesthesiologist versus CRNA. Absolutely. And certainly the doctors have gone to school and residence for a lot longer than the CRNAs. But it doesn't matter. If at the end of the day, what they're doing is a substitute for what's needed, the pricing should get closer and closer, and salary should get closer and closer. I guess the greater challenge is in any area where the costs become there's two things that drive automation. Costs become so high that it forces innovation towards automated type solutions. Right. We see this in some hospitals now where they're able to replace some of the staff on floors. There's the first beta testing of using robotics to replace staff on floors to do things that people were doing, and just purely by necessity, purely just either they can't hire them or the costs have become so insane that they have to use robotics instead. And you see this with revenue cycle, for example. And again, anesthesia, like many specialties, this great mix of art and science. So at what point can you dispense more automatically with less need for doctors and CRNAs and so forth? And that's a longer term automation issue and challenge that comes though on the cusp of just either not enough CRNAs and MD anesthesias, or the cost becoming so high that people look for different ways to deliver anesthesia. And again, anesthesia, like most of medicine, is a mix of art and science, so not totally prone to automation. Certainly with robotics and surgery, more and more robots used, but they're not replacing surgeons at all. It's just a tool for surgeons to use. So that's not a replacement at all. That's just a tool to be used by surgeons. In other areas, reading of images, more and more belief that AI and reading of images will cut down the need for as many radiologists and as many people to read images. Anesthesia is somewhere in between, is at some point does the human cost of this belie such a high price that you end up seeing trends towards automation, and that's still some distance away.
There was a machine, an anesthesia machine that was developed called the Sedasis to use during GI procedures, and it fell by the wayside because at this point it seems that anesthesia is pretty difficult to automate at this point. Whenever I was AANA president, that it was kind of a big deal, and I went and I visited the factory and all of that. That's a whole other conversation. But I guess listening to all of this, my question to you would be, are there opportunities that we as CRNAs are missing right now that we need to be thinking about?
No, that's a great question. And I know that on the automation side, I think what happens with all these things on automation, there's a point at which there's sort of a Venn diagram where costs get so high and the technology catches up to where these things start to make sense. And they've not quite caught up to that spot, but that's what you ultimately see in different parts of the economic situation where the cost goes so high and the technology gets better to where it becomes a better solution. But your point is well taken. You looked at it firsthand, and at this point in time, it wasn't a viable solution. And it's sort of fascinating. Are there opportunities for CRNAs? I think there's what the beauty of being a CRNA today, or being a PA today, or being a physician today, is there are so many opportunities. And it's really a matter of the same advice that I give to my children, I give to younger people that we mentor, is it's ultimately figuring out what do you want to do with your career. You're at, to go to Jay's point, you're at an absolutely beautiful time in the business, in your career. Beautiful time. Yes, it's very hard work. So I don't want to understate that. Very hard work. But you're at this wonderful time where there are job options for anybody that comes out with a CRNA degree that doesn't have some kind of ridiculous reason why they wouldn't be hired. There's just a lot of jobs out there, and so you've got this wonderful time. And then the most important thing that I see towards long-term career happiness, and remember, I started off as a young lawyer, and there's probably very few professions where the young people are less happy than in the law profession. We spent working at the mega firms. It's almost like being a young resident or a young investment banker or young this, young that. The financial rewards are great, but the hours are insane, and you feel like a cog in the wheel. And what we ultimately came to the conclusion that the happiest lawyers were those that ended up deciding, this is what I want to do with my profession. And I think it's largely true of most people in most professions. I mean, for example, Jay's in the financial wealth advisory business, you're in the CRNA business. At the end of the day, you've also been able to carve out a way of doing life, a way of doing business that it seems to me you both love. That, for example, and neither of you followed the traditional path. Jay was a financial advisor who ended up in a niche practice, which I'm a huge fan of. You're a CRNA that both has been president of the association, does locums work, has lots of freedom, is drinking mimosas today. I mean, this is you carved out but you've built a life and a career that doesn't fit somebody else's exact notion of what it should look like, but it fits what you two think your career should look like. You run a podcast that's got 1 million downloads. I mean, you've done things that you want to do. And it's really the same advice for a young CRNA or a mid-level or an older CRNA. The beauty is you've got job security.
Right.
So now that you've filled that part of Maslow's hierarchy, you're going to get fed. You could support your family. Now, what else do I want to do? What's interesting to me? Do I want to be a leader? Do I want to be a leader? Do I want to be part of a business? Do I want to host a podcast? Do I want to write? Do I just want to have a job? I tell people there's nothing wrong with deciding I just want to have a job. I just want to make a living. I want to do my shifts, and I want the freedom to live life I want to live it. That's fine. Or you could choose I want to have a job, but no, I really want to have a profession and be a leader. And that's true too. I want to be the best CRNA in this area. I want to run the program for a major medical institution. And any of those work. The key to me is that you've decided what you want to do. And so
I'm sorry, go ahead.
No. So that to your point on that, I don't know but I've seen many CRNAs. The first CRNA I really came in contact with very closely was a CRNA who was a partner in a surgery center in Ohio that I was advising. And this was 30 years ago, and this was new to me. The fact that a CRNA had been so involved in everything. It was a place where they couldn't get anesthesiologists. And this person had become a real leader within their situation. It was fascinating to watch. It was great. But there's so many different things you could do as a CRNA, just like there's so many things you could do as a financial advisor or a lawyer and so forth. But it's deciding, what do you want to do with it?
As a CRNA, you spend years preparing yourself for this career, so we don't want to see you lose out on any of the income you've worked so hard to earn. The best way to protect yourself and give you the confidence that a major life event won't disrupt your financial future is through disability insurance. We've known disability income specialist Robert Smith for many years and have seen the work he's done with nearly 2,000 CRNAs over multiple decades. He can help identify any gaps in your existing coverage and fill those gaps by finding the best value on a policy. Contact Robert and let him know you heard about him on our podcast. Send him an email at rsmithjr@financialguide.com. That's rsmithjr@financialguide.com. Or call him at 504-394-6557. Protect your greatest asset as a CRNA, yourself and your ability to earn a living by adding disability insurance to your financial plan.
I've got some thoughts on what I think would help our current situation. And I'd like to hear your thoughts on it. From somebody who is somewhat outside as yourself looking into our community, yes, we have gotten better between the acrimony between our organization and the anesthesiologist organization, somewhat better. On the other hand, there's still a lot of acrimony, and it still comes down to, hey, I'm the doctor, you're the nurse kind of thing. One way that I think could really save the healthcare system, and I've told many, I do a lot of advocacy work, lobbying, et cetera, and I'll talk to the hospital systems. There's low-hanging fruit out there that they're just not taking advantage of. And instead of mandating, okay, for reimbursement, they have to have 4 rooms to 1 anesthesiologist, that's a reimbursement model through Medicare. But if we would actually base our work and come up with models based on acuity, if I'm working in endoscopy and I've got class 1, class 2 people, and I'm doing 20 cases, I don't need somebody there to be my second, basically, that you're paying for them to quote unquote supervise me, right? What if they base things on the acuity level and what the real needs are of the patient? And to me, if we would look closely at our models and do not feel like, okay, you got to have 1 to 4. I mean, there's no reason. I've worked 16 years in office anesthesia without an anesthesiologist, okay? But all of a sudden in a hospital situation, you've got to have these mandated models. And to me, that's low-hanging fruit for these hospital systems. And I don't know what we're missing, why we can't. Well, I do know the answer to that, why we don't get more pickup. Yes, Jeremy's doing his fingers. It's money, and part of it's culture. Yeah. Part of it's culture. It's still you're just a nurse and he's a doctor, and there's still that gender piece in it too. I can be with a CRNA walking down the hall, a male CRNA, and somebody will go, "Hey, doc." "Hey, Sharon." Well, in reality, I'm the one who has the doctorate, but there's the gender piece. But that I think we're missing. I think hospital systems are missing a huge boat. I know Atrium in Charlotte did change their models up to better reflect acuity level of patients, and they've saved millions of dollars, but somehow that information doesn't make the headlines so much,
Yeah, no, Sharon, Jeremy, I think it's a fascinating point. I think the thing that happens, as you are well aware, is there's a lot of things that don't make sense, and they generally don't get changed until there's a true necessity, until someone in power sees a true necessity. So, for example, you've had this real back and forth dialogue. You've got some states in the country trying to constantly increase the nurse to patient ratio. So you need more nurses per patient. And of course, that all sounds good from a patient safety perspective, or a very generic, like no surprise act, sounds good from a very generic patient advocacy, patient safety perspective, but we know that it really isn't the most impactful thing at all. It just is something that politicians could point to. See what we did in California we required the hospitals to have more nurses per patient per floor, and that you put hospitals in an impossible situation.
Yeah.
But to go to your point, in states where you don't have that regulatory climate, what you ultimately end up with is hospitals where you end up in a much better position regulatory-wise. It's not so much where the CRNAs and the anesthesiologists are on the same page. It's where the CRNAs, the anesthesiologists, and the hospitals are on the same page. That's where you end up being able to make some of these changes. Because then you've got, the hospitals are still very powerful legislatively and politically. The payers are incredibly powerful. And the payers, unfortunately, are often on the other side of these discussions and disputes. Mm-hmm. But the payers might not be on this issue. But what you do have is hospitals and health systems, very powerful in Washington, very powerful in states. When you talk to any representative, the first thing they'll ask you about almost any healthcare policy change is, how does this impact the local hospital in my town? And again, they're not wrong to ask that question. Often the case is that local hospitals, the biggest employer in their local town. So asking that question is a relevant question. But what happens is hospitals and health systems by necessity say, do we really need 10 CRNAs here or 15 doctors here, 15 MDs here, when in fact this could be done by 5 or 6. It's when you have that and the hospitals are paying the subsidies for those 15 to 20, that's where you have the motivation to make these changes you're talking about. Because that's sort of my perspective on it.
Yeah, no, I totally agree with that. I want to kind of, because you mentioned something there, and Scott, what do you think is going to happen? We're seeing rural hospitals close, at a pretty good clip, or they're getting bought up by larger organizations. Can the rural hospitals survive in this environment, or what's going to happen there?
Yeah, so I think rural hospitals that thrive will largely be doing what they are great at, and they'll probably have limited, unless they're of a larger size, serving a broader rural community, they'll probably be pretty limited in what they provide. They'll have to provide those things that are absolutely very primary care driven, and also what you hear is things that are very time sensitive. So stroke programs. Local rural hospitals still have to have stroke programs, so the kind of things that if patients taken care of within a couple hours, good results. If they're taken care of within 10 hours, horrible results.
Right. So
you do have certain things like that, but you'll very much will have this dialing back to what absolutely has to be done locally, what doesn't. And we were sort of during the pandemic, there were very few hospital closures, but that was because there were great economics being provided by the government. As that dried up, we're on the cusp again of seeing the potential for lots of small hospital closures. And you used to have, again, like you said, large systems that would buy these up as a hub and spoke model. They'll buy up the small hospital, have it send cases, bigger cases, more important tertiary cases, to the regional hospital, the regional hub. But more and more, those large health systems have to be so careful on expenditures today that they don't necessarily want to take on that rural hospital. So we'll have to find a way. We're going to end up in a situation as the profit centers of a lot of hospitals and health systems get gutted. We'll see ourselves as a nation having to find ways to support the hospitals and health systems in a more specific way.
All right. I get your Becker's Hospital Review newsletter every day. And for instance, one of the headlines was hospital losses. Providence lost $1.1 billion in 2022. I've never quite understood this. If any other business lost $1.1 billion, they wouldn't be able to keep their doors open. And I worked with a legislator for a long time, and he always told me that hospitals do fuzzy math. And you're a CPA, you're in a space that should know. The way he explained it to me is hospitals will say, I billed $500,000. They'll just take the number $500,000 for a heart surgery. I'm just throwing numbers out there. They really only get $300,000. So they say that they lost $200,000, which they never had in their hands anyway. So
yeah, that's a very different thing than what's being reported here. What he's talking about is it'd be like you as a CRNA billing out X amount per RVU per unit, whatever it is, and getting paid a fraction of that, and saying that the difference was charity care. You follow me?
Yes.
So hospitals have always said, and they've always reported their charity care, at least often, in what I would call fuzzy math, and that's very different than what you're talking about here. What you're talking about this year is, Kaiser lost $1.3 billion last quarter. Cleveland Clinic lost $1 billion. Providence lost $1.1 billion this quarter. What you're looking at here is true losses, true economic losses. Revenues this amount, expenses this amount, and expenses just out, being larger than revenues. And they could sustain that for some period of time. But what you're seeing is another report that we saw was cash on hand at the major systems is actually falling. And that reflects the fact that you've got true losses. Just like running a CRNA practice, all of a sudden we're sitting on 200,000. Yeah. We've had a bad quarter. Now we're sitting on 160,000. We're still okay. We've still got, in the hospital system perspective, a balance sheet, or the ability to borrow. But at some point, those numbers catch up. I mean, and you sort of see right now, we've had two major hospital closures in the last year. This Atlanta Medical Center in Atlanta. You've also got a hospital center closing in Pennsylvania. And what you're seeing is that is causing the overwhelming of the other local systems around them. Right. So, I mean, those are systems, real losses, real closures, and nobody to backstop them. And it's all, some would argue, well, that's okay in the spirit of getting to a more efficient system. But what's really happened is the people that are taking over the care of those are overwhelmed as it is. And so at some point, you've got multiple different things that have to happen. Yes, hospitals, health systems probably got to get X amount more efficient, but why? They've had, and we've all had the world changed around them. You're in the CRNA business. If I talk to many nurses today, they will say, I want to work any place but in an inpatient hospital. You follow me? Well, a lot of nurses will say that. And again, everybody's perspective is all over the place, but there's been a huge vacuum of nurses out of the health system for multiple reasons. They want to work in other parts of healthcare. The job market has been so great outside of healthcare. They want to take the chance working outside of healthcare, and we're not producing nurses fast enough. And as we do produce nurses, those nurses don't want to stay in the business for that long. So you've got a number of different challenges going on that are very macro changes in the remote work environment. This is not a fault of, the hospital systems are largely these huge not-for-profits. They, nor most other people, were able to anticipate the huge wage inflation and the huge movement of jobs away from hospital health systems, or just the shortage of workers and employees. So it's a real challenging situation. But I don't think these are artificial losses. This is not the fuzzy math that goes into charitable. Here's how much charity care we did. I think these are real losses that are devastating. And I think hospital health systems, you got to have to figure it out or get help from the government. What you're seeing now is hospital health systems laying off anybody who's not clinic facing or anybody that's not in IT. So you've got lots of layoffs going on, again, across systems of mid-management. And you could say, well, they shouldn't have hired that much mid-management. Well, the last few years, they needed all that. And so I'm not sure what the right answer is, but I think it's easy and convenient to play in the health systems, but they're playing a difficult game.
Well, the Fed likes to see those layoffs these days, Scott. So, maybe that'll ease off on some of these rate increases, and we can get some clarification in the markets a little bit. But I'll digress about that for a minute. But, as we talk about more of the macro level here, if we kind of look more long term and the vision the next 10, 20, even 30 years, I mean, Scott, you and I both know, and Sharon as well, that you cannot continue to run at the pace we're at. I mean, you can't lose $1 billion here and $1 billion there. It just doesn't work long term. So, we've got some options. I mean, we hear about the public option here. What's going to happen? Is the government's going to take over? Going to be in a one-payer system? You still got kind of the free enterprise, free market, private option out there, and then Medicare for all. So we've got these options. What does this look like in the future? What are your thoughts around that?
So this is a great question. I think if you would have asked most people a year, 5 years ago, 10 years ago, they would have said any concept of a public option, Medicare for all, was anathema, and don't even get us started on it. You hear every political season has become big issues. Yeah. The challenge that you have is you're already at a spot where more than 50% of healthcare is paid for by Medicare or Medicaid. And so the most ridiculous campaign slogans a few years ago were "Get the government out of my Medicare," because obviously Medicare is a government program. So these are campaign slogans and posters that made no sense.
Well, they are politicians, Scott, so we expect
they are politicians. But the flip side is only 15% of pay is through Medicare. So only about 15% of care is to Medicare, about 35% or more is to Medicaid. So when people try and do Medicare for all, this would be a huge change to our system to really change it to Medicare for all. What's happened is the big payers are now making so much of their money running the Medicare Advantage and the other programs. So what's happened is you've now bastardized Medicare in the name of sort of we're going to get cost certainty, or we're going to get a capitated environment and stuff like that. And what's really happened is we've now added, you've got the commercial payers on one hand, and now you've added a middleman to most of the Medicaid plans and the Medicare plans, and the big commercial payers are filling that role as well. So the sort of the demise of it all, the demise of truly a multi-payer system would be a situation where the four big payers end up really both being the commercial payers for 40-50% of the population, and then capitating or running Medicare Advantage programs for everything else. I mean, and you're still a distance from that, but it's not that far. And then at some point somebody says, if we're really moving towards this capitated system where everything's sort of jammed through these four payers, why do we need those four payers? Why don't we just move towards the government running the whole thing? And who knows where this turns out? You know, we had a panelist last week whose system is 81% Medicare and Medicaid. You know, in the old days for a health system, this was a disaster. Right. This was the last thing you wanted. Now that health system felt like they were doing okay. You know, that they were doing okay. They're in a state where Medicaid pays well. So they were good, not great, but good. And so they felt like that was easier than dealing with the 90% that's commercial. Now, if you remember, we all remember 10 years ago, 40% of your business was governmental, and the other 60% was commercial. And that other 60% subsidized the 40%. Right. Now, as those big payers have more and more power, that is less the perception that those big payers are subsidizing the rest of their business, more that those big payers are very challenging. So I don't know where you go. You know, when people say it's just a free market game, well, it's not, because we're already 50% plus Medicare, Medicaid, and the government subsidizes residencies, all kinds of other things. So we're never going to be a true quote unquote free market. When somebody says Medicare for all, well, it's not that either, because it's only 14-50% of the business is Medicare. You know, different states tried to adopt quote unquote a public option. So I think the state of Washington tried to adopt a public option. Massachusetts might have a public option, or one of the other northeastern states. And those have been economically a disaster for those states because they're dealing with the same supply demand problems that we're all dealing with. Yeah. They just can't get enough hospitals, pay doctors, everything else to make those public options work and anywhere near a good price. You also have, but you have a lot of those challenges. I mean, you've got real, you know, California tried to put a market cap legislatively in how much a hospital could charge. And that's fine, but then you have to cap what the costs of work and everything else, because they just can't make it work. I mean, the California Hospital Association thinks it's well-meaning, or at least politically well-meaning. They think there's a reason behind it, but it's often really poorly thought out, or just playing to a political constituency with no real sense to it.
What did you think about them trying to cap nursing pay? I mean, the nurses lost their mind, and rightly so. They've never kept CEO pay, physician pay, but yet they were going to they tried to cap traveling nurses pay.
Yeah, no, it's obviously ludicrous. I mean, we're in a free society. If a nurse can work for someplace else, and be able to take care of their family for several years and be able to make a living, this is what it is. And this is sort of like a supply and demand issue. At the end of the day, we've got it. In the old days, we created enough nurses, we imported enough nurses, and those nurses, like, the job was attractive enough that it was a great living for a nurse. I mean, a good living. And so we've got to import more nurses. We've got to create more nurses. We've got the medical education system in our country creates great doctors and nurses, but it creates them in a way that was built before the internet. So listen to that. We built the medical education system before the internet was developed. So what happens is you've got this apprenticeship situation for doctors where you go to med school for 4 years, then you go to residency for 4 years, then you do a fellowship. So you're not done to 31 or 32. And the idea that you're going to memorize so many things. Well, you don't have to. You have to be a great learner today to be a great doctor. You have to be a great learner today to be a great nurse. But you're not going to learn everything in those first 5 years because everything changes anyways over time. Right. So you have to be able to learn and get better. We've got an education system that's very, very outdated. And so we produce in India, people are produced as doctors are out practicing by 26, 27. Here it's 31, 32.
Yeah.
In some states, they've got expedited, accelerated nursing programs where you're done and in and out quicker. The cost benefit to get into the profession is much, much better. And we've got to get to that spot. I mean, the countries where they've not kept up the supply and demand of doctors, nurses, staff, it all sounds good on paper, but in the long run, it's a total disaster. So we need, at the end of the day, enough nurses, doctors, staff to take care of people. We just need it. I mean, you've seen countries where they don't do it, where they're just, the numbers are out of whack. I mean, there's India and China are countries with 1 billion plus people. They don't have enough doctors and nurses. Whenever there's a disaster, it's a disaster.
Right.
We don't want to be in that spot. And those are great countries. I don't mean that as negative. India does a better job of turning out doctors than almost anybody in the world. There's just 1 billion people in India, and we are fortunate in our country to be the beneficiary of so many of their immigrants.
Yeah,
and we need more of them. But the system, the idea that they'll be able to solve the problem through prevention, is a politician slogan that is a move in the right direction that might make a dent. But at the end of the day, we need enough care providers to make this work. We have 330 million people, an aging population. We need to be in a spot where there's enough caregivers, enough hospitals, enough providers, enough nurses, enough doctors, enough CRNAs, everything. And we've got an education system that's massively outdated.
Today's show is brought to you by the folks at CRNA Financial Planning, an independent consulting firm that offers financial planning services exclusively to CRNAs and their families. From planning for a child's future college expenses to building a predictable income stream in retirement, the firm is committed to offering you comprehensive financial services, customized to fit your unique needs and objectives. If you have questions about your financial future, get them answered. Call the team at 855-304-3748. That's 855-304-3748. Or go online to crnafinancialplanning.com.
I want to kind of wrap us up a little bit here, but I also wanted to hit on private equity. I know you've got some background there. So, not only in the nurse anesthesia arena are we seeing private equity involved, but I mean, we're seeing it all throughout healthcare. And let's talk about that for a minute, because if these costs are exceeding, what's going on, why in the world is private equity getting involved?
Right. So what's happened, it's a great question. You got private equity has been involved in sort of healthcare in different ways forever. And in private equity, it's fascinating because there's different kinds of private equity. There's private equity that we used to call healthcare light, which is all the business services behind healthcare. So it'd be a private equity fund investing in, say, a revenue cycle company, a technology company, something that provides services to hospitals, to practices, to everybody else.
Right.
That's what we used to call sort of private equity healthcare light. Private equity healthcare is they're actually rolling up, putting together groups of physicians, groups of doctors, they're owning hospitals, owning providers, owning all those kinds of things. So you got those two different parts of the business. Then you've got a completely different part, which is private equity / venture capital, investing in what we call biotech. New drugs, new therapies, new things. And let's take it as a totally different realm of the world, and not as directly applicable day to day, but long-term can come up with real solutions. Like you look at multi-cancer early detection being done through blood tests. That would be biotech versus provider healthcare or provider-light healthcare.
Right.
Provider healthcare, which we've gone through different cycles of this. You and I, Jeremy, are old enough to remember a period of time when the practice management companies that were put together, private equity funds, this goes back 20 years ago, all sort of blew up because economic models blew up when things got tough.
Yep.
Enough debt on all these things and margins got tighter. And so what you see now is you had lots of different roll-ups. It's almost like the roaring 20s. Everything goes well during the roaring 20s as long as you could exit before the party, the dancing stops.
Exactly.
And so you've seen a lot of that. And what happens now is you've got now practices selling into these practice platforms that are all of a sudden very anxious or interested in selling in that weren't a couple of years ago. And it goes back to what you said about interest rates and inflation and stuff like that. You've got physicians in their 50s. They've seen their portfolios take a big beating this year. The NASDAQ down 25, 26% or so. The S&P down 16, 18%, depending what day it is.
Yep.
Portfolios go down at a time when the margins in their practices have also gone down. Because the practices essentially, just like hospitals, like many versus hospitals, the practices see the revenue sort of flat and their costs of staff and supplies, everything else going up, so the margins are down. So you got two big hits to practices. private equity's not immune to that. I mean, private equity's not immune to that. They're in the same spot trying to roll these things up. You see private equity funds build their businesses on two things, just like any business: organic growth and then acquisition growth. Mm-hmm. And what we see as a debacle is when organic growth is going in the wrong direction, margins are going in the wrong direction, and they're trying to acquire their way out of this. They're trying to acquire growth to sort of build beyond all that, and then essentially sell to the next person.
Right.
But no, I think the private equity in healthcare it's been a big win for private equity in healthcare over the last decade or two, and it's coming into a challenging time like all of healthcare.
Yeah, well, and with rates going up, I mean, we're seeing multiples going down, and I mean, it's an interesting time all over the place. I mean, we haven't seen these type of rate increases in a very long time, and obviously that has a big effect on a lot of different pieces, and private equity is one of those. I mean, anytime you can get free money and lever free money and ratchet it up, that's what you want to do, and now money's starting to cost something, and you're seeing less and less deals out there.
Well, no, Jeremy, you couldn't have said it better. I mean, all of a sudden you have something that was, 5-6% interest on debt payments on secondary debt, 6-7%. Now it's 9-10%.
Yeah.
4% on $100 million ends up being $4 million a year. It's real money in terms of margins and so forth.
Yep.
That you got to sort of play through to make sure you make a profitable business, or whatever the numbers are. But you're adding 400 basis points in the last year to the Fed funds rate. Yep. Has a big impact across all these areas.
Yeah.
Absolutely.
Well, as we kind of round this up,
do we have
Scott,
to stop? I mean, do we really have to stop? I mean, I'm having such
I
a
know. We could go on forever. But, disruption is the word of the day. So can you tell me what bold moves do you think that CRNAs or our association should take at this point to position ourselves as healthcare leaders and what we could do for our profession for the future?
Yeah, no, that's a great question. And quite frankly, I'm sure Sharon and Jeremy, you've got better answers to it than I do. I think what's got to be fixed is, the supply demand imbalance of what we have in terms of nurses, doctors, staff, techs, et cetera, versus our aging growing population is just a looming disaster. And Washington would like you to think it'll be solved through preventive medicine and population health. But we all know, I just don't believe that's the case. I think that leaves us upside down just upside down day to day. The thing I'll tell you is people talk about coverage and access. We're down to a spot in our country, and I'll get to an answer to your question, Sharon, I promise. And Jeremy, we're at a spot now where more Americans as a percentage have coverage than we ever had in our country ever. So we're at 92% or so are covered. Yes, we should be at 100%. Whether you're right or left, whatever perspective, we should all be covered. But coverage without access is sort of, it's very superficial. So yes. we have better coverage than we've ever had. I think all of us would agree that our access is no better because there's just not enough doctors and nurses.
Worse, yeah.
So if somebody wants to figure this out, like they talk about the nursing shortage is often a function of not enough faculty to teach nursing. Is one of the things you hear often is this is the stopgap, this is the limiting step. There's not enough faculty to teach nursing. And if that's the case, we just have to update how education is done in our country. So I view it as at some point we'll automate a lot more, but we always talk about recruit, retain, and automate. Recruit and retain people and automate what you can. At some point we'll automate some of this out of the equation, but not for a very long time, and maybe not effectively ever. Who knows? But in the meantime, the next 10, 20, 30 years, we better figure out how to create a lot more providers. It's not that we need to totally flood the zone, but we need enough providers to take care of our people. So if you could figure out a way to educate people quicker, more efficiently, better, produce more CRNAs, it would solve a lot of problems. Particularly, you're in a situation where most professionals today, in the old days, if you're my age, I've been in the same job for 30 years. People don't do that anymore. People don't do that anymore. It's just not how the world works anymore. And so you're in a spot where, you produce doctors, you produce nurses, half of us end up sort of partly out of it or partly doing it part-time at a certain period of time. I don't bill hours like I used to, but somebody's got to bill those hours. Maybe they don't, but the idea is the same.
The firm wants somebody to bill those hours, whether you're doing it or not.
Firm wants it. They sure do.
Well, the other thing that I think needs to be considered outside of the faculty. I agree with you at one point, but 80% of nurses now would not go back into nursing. They would not advise their offspring to go into nursing. That's a problem. I mean, we might wind up having all the faculty in the world, but the pandemic has absolutely killed the nursing workforce. They've worn them out.
Yes, 100%.
And they're leaving in droves.
Yes, and you 100%. So the stats are something like 800,000, 1 million nurses have left in the last few years out of 5 million. That's 20% of the workforce is left, and that 20% remaining does not want to work largely. Not all, not completely. Doesn't work on hospitals, health systems. Wants to work on all sort of alternative sites. And so what happens is, how do you create enough nurses, and then how do you move it towards much, much more where it doesn't have to be 60 hours a week, where people could work the shift they want to work, make a living, have the flexibility they want. Like people talked about during the pandemic, they talk about all these nice things you do for people. Oh, we're going to get them a massage. We're going to have them do deep breathing. We're going to have them do meditation. Let me tell you, when my first job, I was working 80 hours a week. Somebody could have done all those things for me. It would have been irrelevant. It didn't matter. It doesn't matter. It doesn't matter. You could do everything you want. But if I'm working that hard and going to a field of combat where I got to worry about my own health and sickness, you could do all these cute little things you want. But unless you're making sure there's enough people so I can get a break, so I can take the day off, so you do things they need to do, you're going to burn people out. I mean, because you go around it.
This is as much a cultural thing as it is anything. You know, I look at this and I go, I mean, the millennial group, they don't believe in work the way, I mean, we're all similar age here. I mean, they don't believe in working the way we did. They don't believe in working 80 hours a week and busting your butt to get there. That's not the culture that they've been brought up in, ingrained in. It's a different feel nowadays. So somebody has to figure that out as well.
Well, no, but you're absolutely right. But if you and I know that at the end of the day, it's much easier as an employer to have one person doing 60 hours than 3 people doing 20. Because now I got to manage 3 people doing 20.
Exactly.
But as an employer, you don't have that choice anymore. You don't have that choice anymore. So you better figure out how to then you need enough people that want to each do the 20 hours a week so that you could make this all work. Right. But it's not, you see more and more solutions around this, but you need enough. If you're going to have people not working, I'd rather have full-time employees. It makes my life easier within reason. I want part-time super. I want people fully engaged in what they're doing. But if that's not the workforce, then I got to figure out around it. But forcing somebody who wants to do 20 hours a week to do 40 hours a week is a very short-term solution because that person won't stay.
Absolutely. And that's what's happening, I believe. I really do.
100%.
I think that these folks don't want to do, Sharon, what you had to do and what Scott had to do at the law firm and what I had to do when I started the business. That is not in their makeup anymore. It's just not. And that's another whole issue that, we could probably have another whole podcast about. But.
Well, there's still another issue, and I swear I'm going to stop after this.
I'm going to have to put a fire hose on you because.
But what I'm going to say, Jeremy, is we know that nursing workforce is the backbone of our healthcare system, and yet whenever we're trying to search for solutions, nurses are not at the table. Yeah. They're just not. Now, I'm sure Becker's Healthcare has a lot of nurses up and down within your conglomerate, I'm sure, because you would have them there, the people who are the backbone.
What you have is a few of the great CEOs in the country. Jenny Spiso, the CEO of UCLA, Nancy Agee, the CEO of Carilion Clinic. I mean, there's a number of the great CEOs in the country are nurses, and more you see nurses, doctors, CEOs. It's very, very critical to our system, that perspective, that compassion, intelligence, discipline. I mean, they make for great leaders. And this goes back to our early conversation. If you want to be a CRNA and figure out what you want to do, the sky's the limit. Do whatever you want. You got a great platform, but you have to figure out what you want to do. Sharon and Jeremy, I know we've got to wrap up. I know that I'm at the spot where I know I've got to drop off in a second, or I'm going to get shot here or in trouble here. Maybe not shot, it's a bad word, but I'm going to be in big trouble.
Yeah. Well, I tell you what, let's wrap there. Scott, I know we could go on with you forever, and we really appreciate your time. It's been engaging, and I've really enjoyed it. And I can tell from the way Sharon's asking questions that she is too. So thank you for all you do for the healthcare industry and what you've accomplished. Much to be proud of, and we thank you for being on our show.
Thank you very much for having me. What a pleasure.
All right. Well, Sharon, I think it's a wrap. We want to thank our listeners for listening to Beyond the Mask with Jeremy Stanley and
Sharon Pierce.
If you like our show and want to help us grow, Sharon, how can they help our show grow?
Well, the best way to help us grow is to leave us a review, but make it
positive. We know there's way too much negativity in this world.
Absolutely. Share us on social media. Tell your friends. We're in the top 50 medical podcasts in the country, and we'd like to be number.
We'd like to be number one. Well, we got to let Scott be in there too. So we'll be behind him.
Yeah.
How about that?
Yeah.
No,
Yeah,
we'll be behind. You guys are fantastic. Thank you.
At least in the
so
top
much.
10.
All right. Until
All
next
right.
time.
It's a wrap.
Have you thought about what would happen if you weren't able to work for 2 or 3 years? On average, 25% of people will file a disability claim, and most of us aren't prepared for that loss of income. Every CRNA needs to protect their biggest asset, yourself, and your ability to earn with a disability insurance policy. We recommend contacting Robert Smith, a master disability insurance specialist with more than 30 years of experience and 1,800 CRNA clients, to find the coverage that fits you best. The best way to do that is to send him an email at rsmithjr@financialguide.com. That's rsmithjr@financialguide.com. Or call him at 504-394-6557. Beyond the Mask is made possible by the team at CRNA Financial Planning. With almost 2 decades of experience, the firm guides CRNAs through the complexities of investing and financial planning. Schedule a free consultation today by calling 855-304-3748 or go online to crnafinancialplanning.com.
Hi, this is Jackie Rolls, President of the International Federation of Nurse Anesthetists and President and founder of Our Hearts, Your Hands, a global anesthesia support community that takes donations to allow nurse anesthetists in low and middle income countries to go to educational programs, buy equipment, or textbooks. Your donations are tax deductible, and we would appreciate your support.
OSA EMR is a free anesthesia EMR developed by CRNAs that you can download and use on an iPad. Our nonprofit mission is to make sure that solo and small practice CRNAs can digitally record their anesthetics. To learn more, visit osaemr.com to download and consider donating to our cause. Remember, for CRNAs, data is destiny.
Be sure to subscribe to the show on Apple Podcasts, Google Podcasts, Spotify, Stitcher, and anywhere you like to listen to shows. Also be sure to check out BeyondTheMaskPodcast.com. Each episode is posted there with a corresponding blog post, and we timestamp important parts of the episode to help you quickly get to the content you're looking for. Also check out the special series section on the site. You can follow along and catch up on the CRNA History Series, episodes specifically about political conversations in the industry. Or try the CRNA Personal Finance Series. It's all on BeyondTheMaskPodcast.com. And if you have a question for the show or want to be a guest, or even suggest a particular topic, fill out the contact form on the site or send an email directly to us at info@BeyondTheMaskPodcast.com. And lastly, let's take the conversation social. Check out our Beyond the Mask podcast Facebook page and Facebook group.